To everyone. We are going to have another session. This and previous teaching hospital Anuradhapura and also District General Hospital Kegal. So Dr. Chathura is going to talk to us about a very important and very common topic about abnormal liver functions, which should be very important for all the new doctors and students as when you practice as newly qualified doctors. So without taking much of Chathura's time, let me thank him again for invitation. Welcome you to do presentation. Over to you, Chathura. Thank you.
Thanks, Dr. Duminder. Good evening, everybody. So the today's topic is basic interpretation of common liver function abnormalities. So first of all, I must thanks PeMSAA giving me this liver profile. If you arrange the liver function test, it does include the synthetic function. You mean and the bilirubin. So a bit of physiology about the liver parenchyma. So you can see my arrow is going. I hope. So these are the hepatocytes that in the sinusoidal area. In the hepatocytes, you can see that the greenish color things are the bile duct. And blood supply is from the hepatic artery branch and drain into the central vein. So the other blood supplies liver 7% from the 30% from the hepatic artery. So this is the largely system. If there's you will get elevated alkaline phosphatase and the gamma-GT. So if you want to interpret liver test, so first of all, you should know these basic principles. So you should know that where the test is being done. So your lab should be a reliable lab. And the liver test interpretation, so the unit is also very important. So whether it's a milligram per deciliter or the micromole, because it does have a huge difference when you change the units. And then it is important to know the times, the upper limit of normal to interpret that. Because most of the time, various lab give various upper limit, where the interpretation may be different. And the other things you want to know is that whether the patient is symptomatic or asymptomatic, where your management will differ. So I'm going to discuss the liver test abnormality and taking this discussing about these patients. So I have got few patients. So these are real cases which I have come across in my practice. So the patient one, 28-year-old man who has a bit of high BMI and the family history of diabetes, but he is asymptomatic and he takes alcohol at function. So I'll give 1 minute to go through these results and then I'll discuss with you. So you can go through these and then you can think about any possibilities. Can you all hear me well?
Yes, sir.
All right, thanks. So if you have any questions, you can disturb me at any time. So you can ask me, okay? So he is a 37-year-old young male. So what is the striking feature here is that the elevated SGPTOT and the gamma-GT level. So although these ranges or these upper limits are giving us 40 and the 41, it's bit, I mean, it's the real world, it is not the true cutoff. Okay. So here you can see that there is a mild elevation of the SGPT and the gamma GT. So what are the possibilities? So it's very common. So if you, if I want to discuss about the ALT, you know that it's the most liver specific enzyme, and it mainly plays in the cytosol, and it raises in cell damage and cell death. And it has got a longer T-half, which roughly is 72 hours. And the normal values we see in the healthy people are due to programmed cell death, which is called apoptosis. So these are the normal values for the ALT. So remember, although the different lab gives the different values, for the male, it considered as the 30 is the upper limit of normal. And for female, it's 90. So if I want to discuss this patient, so you can see that it's twice the normal, more than the cutoff value. So it is SGPT is more than SGOT, and the gamma GT also elevated. So what are the possibilities? So it's very common condition nowadays. So with the history, you can discuss this is case of a non-alcoholic steatohepatitis, but he admits taking alcohol at function, but it is within the desirable alcohol limit. So the ALT and the AST mainly you can see it inside the mitochondria. So it has got a shorter half-life, about 24 hours, and it is affected by other illnesses. So when you compare any muscle disease or the hemolysis, it also can give rise to elevated AST. So because it's not liver specific. So my second patient is 28-year-old man, was detected to have abnormal LFT at medical checkup. And he is asymptomatic again and visit gymnasium regularly. So you can go through the liver test. I'll give 30 seconds. So anyone can guess that what abnormality you can see here? So what are the striking features? So there is again about maybe 4 times elevation of SGPT and the SGOT around 9 times. So there's a very high SGOT compared to the SGPT level. So but other rest of the liver panel looks fairly normal. So after a few days, about 3 weeks, he comes with this report. So this is the first detected liver test, and after 3 weeks, these are the livers. So SGPT has come down drastically, and the SGOT also, and there's a bit of elevated bilirubin. So forget the bilirubin level, but just concentrate on the SGPT and the SGOT. So what are the causes for AST elevation? So from muscles. So if there's an extreme exercise, as I told you that it's AST is not specific to liver. So it can secrete from the muscle, cardiac or the skeletal muscle. So if there's if the patient undergoes any extreme exercise, it can elevate and it can give rise to high AST level. And if there is a muscle injury, or maybe due to the struggle, accidents, seizures, or the myopathy, it also gives rise elevated AST. And drugs like antipsychotics. And earlier days, it is used to do the AST when you suspect any myocardial infarction, because it is also elevated during the myocardial infarction. So how do you differentiate? So you can do the CPK level, which will differentiate whether it is the origin is from the liver or the muscle. So what has happened to this patient? So in the history, I told that he visits gymnasium regularly. So what has happened is there is a the skeletal muscle injury due to the strenuous exercise, and it has given rise this elevation of SGOT with the SGPT. So why there is a SGPT elevation? Because you know that even in the muscle, although the SGPT is specific to the liver, skeletal muscle also has got a bit of ALT. So that's maybe the reason that SGPT also elevated in this patient, because we expect to have the high AST more than the ALT. So here they have come down after 3 weeks of repeat tests. So these are the causes for AST elevation from muscle. So a few words about the serum transaminases. So as I told you earlier, so the SGPT, ALT is liver specific. SGOT is also found in muscles and RBC. So it was, considered to diagnose MI in the past. So the very high levels, we can see if the patient has got any viral hepatitis. But keep in mind, the degree of damage may not correlate with the severity of liver damage. So sometimes ALT of 5,000 in the viral hepatitis, maybe, the prognosis is desirable if you compare the 500 with liver injury. So what I want to tell you, that the degree of damage may not correlate with the severity of liver damage. So the transaminase, if there's an elevation of the transaminase, we call it as a transaminitis, because there's an ongoing inflammation. So it is transaminitis, not very high in obstruction. So if there's a obstructive origin, you may not see any, very high levels of transaminase. Sometimes it may be normal in cirrhosis, because you know that you need some sort of cell, the live cell in your liver to produce the liver enzyme. So if there's a cirrhosis, which you know that there's a cell there, you might not see the elevation unless there is a ongoing hepatitis. The ongoing insult, like continuous alcohol intake. Right? So the AST-ALT ratio useful in certain liver diseases. So that is very important. Also you see that the AST and the ALT level within normal range, you should expect the ALT always more than the AST level, because as I told you earlier, ALT has a more lengthy half-life of 72 hours. So if there's an apoptosis breakdown, you will, in the blood, you will see excess of ALT more than the AST because of the half-life changes. So usually in the normal healthy people, ALT is always more than the AST. So if you see any patient who has got the AST more than ALT, even within normal range, you should find a cause. Suppose your patient may be having an AST of 15 with an ALT of 12. So you should find they are within the normal range, but still you should find a reason for underlying reversal of AST. So that's what I have mentioned here. AST-ALT ratio is very important in certain liver disease, specifically in cirrhosis. So usually ALT is more than AST because rapid clearing of AST. So what are the conditions where you will see ALT more than AST? Mainly the common conditions are non-alcoholic steatohepatitis. So it's always ALT more than AST. In a viral hepatitis, again the reason is the same, and the autoimmune hepatitis. So what are the conditions? Yeah, you can see AST, that's the reversal of AST and ALT pattern. So if you suspect alcoholic hepatitis, so that is a condition where you see always the more AST than the ALT. And the cirrhosis, obviously, because there was a cell there. And the ischemic hepatitis or the shock liver, also you can see high level of AST compared to the ALT level, and the dengue fever. So, but if you see any reversal of AST and ALT pattern, you should find out whether there is any underlying hemolysis or the rhabdomyolysis, which can give rise to the same liver test abnormality. So the why AST is high. So in cirrhosis, what happens is that there is a vitamin B6 deficiency, which leads to the lower level of ALT, because you need vitamin B6 to produce the ALT. So if there is a deficiency, like in cirrhosis, you will see low level of ALT. And the other thing is, in the cirrhosis, you will have a cell death, where you will have a mitochondrial damage. So 80% of the AST is in the mitochondria. So if there is a cell death, you will see the high level of AST. And the other reason is that because of the fibrosis, there's an underlying vascular, some sort of ischemia with the reduced blood flow because of the ongoing fibrosis, where you will see the reduced clearance of the AST and ALT, but it is marked in the ALT, where you will have a collection of the AST, where you will see a reversal of AST-ALT pattern. Do you have any questions up to now? Am I too fast? Can somebody answer me? Hello?
No, sir.
Do you have any other questions up to now? So as I have talked about the abnormality in the ALT and the AST level. So then I will talk a very common condition, which is a NAFL and the NASH. So the NAFL is a non-alcoholic fatty liver disease. And if it progresses to the inflammation, we call it as a NASH, where non-alcoholic steatohepatitis happens. So it is always, as I told you, ALT, you will see the ALT more than the AST. Usually, very rarely it exceeds, the 5 times of upper limit of normal, like the ALT. So it is usually less than 200. So if you see a patient who has got the ALT of 500, it's a bit unlikely to be a non-alcoholic steatohepatitis. So the gamma GT may be raised because it's a endothelial dysfunction. The marker of the endothelial dysfunction. Because you know that the NAFL is associated with the the liver component of the metabolic syndrome. So you will see vascular endothelial dysfunction with the elevation of the gamma GT. Usually the rest of the liver panel are normal because you will see only the transaminitis. NAFL is present in 30% of adults in in our population, and the 75% of these patients have got elevated liver enzyme. Again, the degree of elevation very poorly correlates with the degree of risk of progression. If you see a patient with the 100 of ALT and another patient with the 60 of ALT, you can't predict the outcome depending on the level of the AST and the ALT. It's very poorly correlates. Again, the degree of fatty infiltration also ultrasound scan also poorly correlates with the risk of progression, because sometimes you have seen the patients which has got the grade 3 fatty liver, the grade 1 fatty liver, or the grade 2 fatty liver. It very rarely tells about your outcome unless there is a component of fibrosis. So what they say is that the NAFL can progress with normal enzyme, because you will diagnose a fatty liver by doing the simple ultrasound scan abdomen, but you may not see any biochemical abnormality in your liver panel, but still it can progress. So what you want is that in that case we need other objective measures like these NAFL fibrosis score or the FIB score. So FIBO is a very simple index which you can, the bedside test, where you need only the age, AST, upper limit, platelet count, and the ALT. So by doing that, you can diagnose whether the patient has got any underlying fibrosis by doing these things without going for invasive procedures like liver biopsy or the other scan like transient endoscopy. So you know that what is the normal, the natural progression of NAFL and the NASH. So you will hear the healthy liver. About 25% of patients, they can progress into the benign steatosis, where by doing the ultrasound, you can diagnose the fatty liver disease. It's called the non-alcoholic fatty liver disease. So unless you do anything, about 3 to 5% of patients, they progress to the NASH, where the patient has got transaminitis, where you will see elevation of the SGPT and the SGOT. So that's why we are calling as a steatohepatitis, because there is an ongoing inflammation, which is called they have got the transaminitis. So if you don't do any, the intervention, about 30% of them progress into the NASH or the NASH fibrosis, where you will see the reversal of SGPT-OT and the ultrasound evidence of early cirrhosis. So of them, 20% of they progress into the decompensated cirrhosis. So up to here, the disease is reversible, but from this point onwards, it may not. To some extent, it may reverse, but not fully. So this is the natural progress. So you get a healthy liver, steatosis, NASH, the NASH fibrosis and the NASH cirrhosis. So then we'll move on to the patient 3. So that patient, a 50-year-old lady, had a cardiac arrest following an invasive procedure due to the concealed hemorrhage. She was resuscitated. These are LFT after 2 days. So you can go through these. Can you see my slides?
Yes, sir.
Thanks. So what are the abnormalities you see here? So very high level of SGPT with the very high level of SGOT. MRG is slightly high, bilirubin is also high, and the albumin is fairly normal. So what is this? So this is called steamic liver or the ischemic hepatitis or the shock liver, where you have seen a very massive elevation of SGPT and SGOT. So what are the conditions where you get massive elevation of SGPT-OT? Mainly the viral hepatitis. So it may be hepatitis A, B, very rarely C, or the other, the non-hepatotropic virus like cytomegalovirus, Epstein-Barr virus, or the HSV, herpes simplex virus. So that is the commonest reason where you see the massive elevation of SGPT. The second to viral hepatitis, ischemic necrosis, where you will get a patient following cardiac arrest, or these days dengue shock syndrome. And the other thing is a paracetamol toxicity. You all know that because of the massive cell death. So the striking feature is how to differentiate whether it's a ischemic necrosis or the toxic necrosis or the viral hepatitis. So the one marker is that if you see AST more than the 3 times of upper limit of ALT, so that suggests ischemic necrosis, which is a ischemic hepatitis. So the other marker is the elevation of creatinine, because you know that if there's a systemic hypotension or the low blood pressure, it affects liver as well as kidney. So if there's a ischemic element to the liver, invariably it will affect the kidneys as well. So with the massive elevation of AST-ALT, you will see a rising creatinine, where the etiology suggests that the systemic hypertension, and it is mainly, it is most likely due to the ischemic hepatitis. So the patient 4, a 36-year-old patient with alcohol-induced cirrhosis, presented with icterus bilateral ankle edema, and he had restarted drinking 2 months back. So this is his liver panel. So anybody can guess what are the what may be the cause for this abnormal liver test? Any guesses? At least what are the abnormalities you will see here? Anybody?
That's high ALP and gamma GDT.
Very good. That is a very, that is a striking pitch. Any other things? So,
bilirubin is increased.
it's very high, isn't it? 8 times high of the normal limit. And can you see there's again SGPTOT? Pardon? Yeah. So can you see that reversal of SGPT, which suggests what? Can it be a patient, it is because of the cirrhosis? Yes, because in the history, I told that the patient is a diagnosed patient with cirrhosis. So that is due to that. So what are the other abnormalities you see? Can you see that the patient has got the hypoalbuminemia, low level of albumin, and the very high level of total bilirubin, and the high levels of alkaline phosphatase and the gamma GT. Gamma GT is, 7 times, nearly the 8 times of the upper limit of normal. So what is the cause for this liver test abnormal? So patient probably, the patient is a cirrhotic. So he has gone into a acute decompensation, which is evidenced by the high bilirubin, low albumin, and the very high levels of alkaline phosphatase and gamma GT. So this is a cholestatic pattern. So if there's a transaminitis with elevated bilirubin, alkaline phosphatase, and gamma GT, used to call it as a cholestatic hepatitis. So what are the, so this is like acute decompensation in a stable cirrhotic, because he has restarted drinking 2 months back. So what are the causes for low albumin? So obviously chronic liver cell disease, because the synthetic function is getting impaired, so they can't produce any albumin. And because of the low albumin, you will see a reversal, again the low albumin, reversal of albumin globulin ratio. Because you know that cirrhosis is a chronic inflammatory condition where you will, the patients produce a lot of immunoglobulin to react, to respond to the chronic inflammation, where you will see the low level of albumin in spite of high level of globulin with the reversal pattern. So what are other causes for low albumin? So it may be the albumin loss, like in nephrotic syndrome, or the malabsorption, or the malnutrition. And keep in mind, even in severe sepsis, you will get low albumin, because albumin is a negative pace marker. Because the CRP, the CRP you consider as an acute pace reactant with a positive response. But the albumin and the cholesterol, those are negative markers of the negative pace reactant. So that's why it is very low in severe sepsis. So patient 5, so the patient who had a liver transplant 2 years ago presented with the UTI, he was otherwise healthy. So this is his liver panel. Anybody can tell me what are the abnormalities you can see here? So what are the abnormalities here? So fairly, liver enzymes are fairly all right, but you can see that the very high levels of globulin, isn't it? Can you see that?
Yes, sir.
All right, thanks. So what are the causes for high globulin? So as I told you, so the chronic liver cell disease is a one cause, which is a very common cause. And the chronic inflammatory disease like autoimmune hepatitis or other inflammatory conditions like sarcoidosis, tuberculosis, and those things. And in addition, you should remember that there are some sinister pathologies like multiple myeloma also can give rise high levels of globulin. So actually, this patient was diagnosed to have multiple myeloma at the end. So keep in mind that the isolated elevation of globulin is considered abnormal and you should need further investigation. So the 40-year-old female presented with yellowish discoloration of the eye and pruritus 2 weeks after starting carbimazole for thyrotoxicosis. So this is her liver panel. Anyone can guess why the patient has got this liver abnormality? So what are the abnormalities you can see here?
Elevated gamma GT and alkaline phosphatase.
And
with high bilirubin levels.
So what is that then? So this is and the elevation of the, I mean, there is a mild transaminitis, isn't it?
Yeah.
So this is cholestatic hepatitis, because you can see that there is a, I mean, where is the pathology then? So as I told you, so you can remember biliary canaliculi, isn't it? So the canaliculi sites, mainly the alkaline phosphatase and the gamma GT are placed in the canaliculi site. So if there's a damage to the biliary pathway, you will see the elevation of the ALP and the gamma GT. With the function, I mean the functional obstruction, you will see the elevation of the bilirubin. So this is due to the drug-induced liver injury, which is called the DILI, which is most probably due to the carbimazole. So high bilirubin, it may be conjugated, which we will see like high direct bilirubin, or if it is unconjugated, it may be it is called as an indirect hyperbilirubinemia. So what are the causes for direct I mean at least the drug-induced liver injury? So it may be hepatocellular DILI, or the mixed DILE drug-induced liver injury, or the cholestatic drug-induced liver injury. So our patient had got a cholestatic DILI. So the patient bilirubin improved over 3 months, because sometimes it takes about 6 months to get rid of this damage and I mean normalizes the liver test. So what are the common drugs which can give rise transaminitis and the cholestatic hepatitis? So mainly the antibiotic like co-amoxicillin, and the antipsychotics like, I mean anti-epileptic like phenytoin, the thyrotox, I mean the drugs given for thyrotoxicosis like carbimazole, and the NSAID, non-steroidal anti-inflammatory drugs. Those are the common drug etiology for this drug-induced liver injury. We call it as a DILI. And keep in mind, sometimes herbal drug supplement, we call it as a HDS, also very important, and you should mention in your history. If there's a liver damage, you should mention that whether the patient has got any drug, herbal drug supplement recently, within last few weeks at least. So the patient 7, the 30-year-old asymptomatic man, was investigated for raised bilirubin. His other LFTs, including ALP, gamma GT, were normal. Liver ultrasonography was normal. His particular site count was also normal. So what is this condition? Anybody knows this condition? It's a very common condition. So what you can see here, there's an indirect hyperbilirubinemia with the elevation of total bilirubin. So what is this? So what is this condition? So this is due to the increase so you have to exclude the hemolysis or the inherited disorders of metabolism, which is a very common condition. It's a Gilbert syndrome. So what is Gilbert syndrome? It mainly affects 10%. I mean, it's not very common, but it's again we can we will come across a lot of patients in our clinic. So they are usually asymptomatic, detected during illnesses, as bilirubin is raised due to fasting. I mean that due to the intercurrent illness or the intercurrent sometimes due to the drugs. And it never reaches very high levels, like maybe less than 50 micromoles, like. So it's never, it never reached like more than 5 milligrams per deciliter, like. And they have got normal life expectancy because it won't progress into chronic liver cell disease. So the most important thing is that diagnosis is essential to avoid unnecessary investigation, because otherwise the people will go for even for the liver biopsy for this, the innocent condition. So what you need is that to exclude the hemolysis and the other causes for indirect hyperbilirubinemia, and the reassurance is the mainstay of treatment. So this is a direct hyperbilirubinemia, Dubin-Johnson syndrome. It's not very common, and there's elevated direct hyperbilirubin, and usually it's commonly presents with icterus during pregnancy, and they are having the normal ALP and gamma. But the problem is during the pregnancy you will anyway have elevated alkaline phosphatase due to the placental secretion. So if you see a Dubin-Johnson patient who is pregnant coming with the abnormal high ALP and the high bilirubin level, you should at least do a scan to find out whether there is any biliary obstruction, because ALP mostly secreted by the placenta, and it may be a normal, it may be normal for the pregnancy. So the patient age, 39 female, present with generalized ill health. She was detected to have hepatosplenomegaly. She was obese. She also had ES of more than 100, and there was a history of severe untreated hypothyroidism, diabetes, and hypercholesterolemia. So this is her liver panel. Anyone can guess what does this abnormality due to? So the history is she has got few medical problem. She coming with she comes with this abnormal. So again, you can see high level of gamma GT and alkaline phosphatase with transaminitis. But rest of the things are normal fairly. So again, this is a cholestatic hepatitis, and so again, the problem is here. So the biliary canaliculi, because high ALT and gamma GT are due to this. Why there is a transaminitis? Because they are, the lining hepatocytes also, if there's a damage here, invariably it will affect the normal hepatocytes as well. So that's why you will see elevation of AST and ALT. So why high ALT and gamma GT? So most probably due to bile duct injury or obstruction. So it may be intrahepatic or extrahepatic. So the intrahepatic biliary obstruction may be due to drugs like, as I told you, Mcqs, NSAID or anti-epileptic, or the primary biliary cholangitis, where you see there is an inflammation in the biliary canal with the cell damage. And then the primary sclerosing cholangitis, so the autoimmune syndrome, or the allograft rejection, after the liver transplant, if there is a liver the liver graft rejection, you will see again the biliary damage. Or if there's infiltration like TB, sarcoidosis or lymphoma, again you will see the high level of gamma GT and ALP. In addition, cholangioCA, gallstone, strictures, which can cause extrahepatic obstruction, also give rise to the same. Unfortunately, by looking at the liver biochemistry per se, we can't differentiate whether it's an intrahepatic or extrahepatic. There you need to arrange the imaging to see whether there is any duct dilatation to differentiate between intrahepatic and extrahepatic causes. So if there's isolated elevation of ALP, it's mainly comes from the bone. So like Paget disease, vitamin D deficiency, if there's a secondary bone tumors, chronic kidney disease, so you will see isolated elevation of ALP. Childhood is very, during the childhood, if you do a liver panel, that incidentally you might see a elevation of ALP. It's mainly due to the bone, the bone turnover. It's due to the growing stage. It's not abnormal. And the pregnancy, as I told you, due to the placental secretion. So how to differentiate whether it is coming from the liver or any other extra hepatic cause? So you can do the gamma GT level, because gamma GT is more specific to liver than the ALP. So you can do the gamma GT and find out whether it comes, ALP comes, elevation is due to the liver or the extra hepatic cause. So patient 9, a 70-year-old man had cirrhosis on ultrasonography. He had recent loss of weight and loss of appetite. So with the history, you can think about any, any sinister processes going on or not. So these are the liver tests. So here you can see low level of hypoalbuminemia, high globulin level. Bilirubin is, elevated, but it's not very high. Alkaline phosphatase is disproportionately high, that is 1074. SGPT 145, SGOT 154. Again, you can appreciate the reversal of SGPT and SGOT with the high level of gamma GT. So what do you think the reason or the underlying cause for this abnormality? Patient is cirrhotic.
Hepatocellular carcinoma.
Cellular carcinoma.
Very good. So actually the patient had an imaging later, and it turns out to be a hepatocellular carcinoma. But what is the striking feature here? You think it's hepatocellular carcinoma per se, or hepatocellular carcinoma complicated with something else?
Secondary.
Yeah, Bhuto, that is also possible. But the other thing is that can you think about any biliary obstruction?
Yes.
Yeah, so that is, if you look at this, if the patient, if you don't get any history, what are the things which comes to your mind? So one thing is the cholangiocarcinoma, because you will see a very high level of gamma GT and the ALP. And the other thing is the hepatocellular carcinoma obstructing the biliary pathway. So that side is very high. It is called disproportionately high gamma GT and ALP. So the patient then, 45-year-old lady, she is obese. With a medical checkup, she is on treatment for ischemic heart disease. Is that slide clear for you?
Yes, sir.
Okay. So what are the things you will see here? Anyone can guess?
High level of gamma GT is there.
Yeah. Bit. Slightly elevated ALT and AST.
AST.
So do you remember, do you remember the upper limit of normal for ALT for female? That's 19.
90.
But if you see this lab, it it is written as a 45, which is which is not the ideal one. So this is nearly twice the upper limit of normal. So this is again the ALT. There's a transaminitis with high ALT, and then there is a I mean the fairly high level of gamma GT compared to ALT. So what is that? So that is again the cause is non-alcoholic steatohepatitis. So what are the causes for isolated elevation of gamma GT? So it's mainly the drugs like anti-epileptic and the alcohol which induces enzyme production. So if you see a patient with a non-alcoholic fatty liver disease, most of the time you will see the elevation of gamma GT because it's a marker of endothelial dysfunction and the oxidative stress. So if you see a patient, if you don't have NAFL, but still if you see a high level of gamma GT, it predicts the development of non-alcoholic fatty liver disease. So isolated gamma GT elevation is not normal. So you should find the cause. Most of the time it's due to the underlying metabolic syndrome with the fatty liver disease. So what are the clinical uses? To follow up for alcohol abstinence. So if somebody if somebody is a regular alcohol consumer, comes with a high level of gamma GT, so that means they are regularly taking, although they won't come up with the history. So to follow up alcohol abstinence, you can check the gamma GT. And the other thing is that to confirm the origin of the ALP. So you remember the case which I have discussed, that whether the patients having isolated high alkaline phosphatase, to confirm that whether it comes from the liver or any other extrahepatic causes, you can do the gamma GT, because gamma GT elevation, both gamma GT and ALP elevation probably due to liver disease, not the other reason. So any problem up to now? Anything you want to clarify more? Anyone understand these concepts? Shall I proceed to the next slide then? Hello.
Okay, sir.
Okay, sir.
So patient 11, 32-year-old man referred by a neurologist for the evaluation of the LFT abnormality. He has had progressive neurological deterioration with predominant motor weakness with extrapyramidal symptoms. His memory is failing. He has a recent seizure. I would like if somebody can, at least to explain the abnormalities, not the causes.
Elevated liver enzymes with transaminitis.
Yeah, very good. Any other feature you can see there? Can you appreciate there is a reversal?
Yeah, S3 more than LT.
It is significant, isn't it? So what may be the cause for that? So usually we will have the SEPT more than the SEOT level, isn't it? But here,
Yes, sir.
so if you go through the history again, so they're referred by a neurologist. And he has got progressive neurological deterioration with motor weakness and the extrapyramidal symptoms. His memory is failing. He has a recent seizure. The thing is that isn't it? Those are, more than 1,000. This is not, this is just above this 100 and the 200. So this is mainly due to the excretion of, excretion from extra liver, the extrahepatic causes. So if you want to discuss that patient, this patient came to negative because the Wilson is the differential diagnosis. Because the patient has got the seizure and the neurological impairment with the liver abnormality. But the liver was ultrasonically normal and the cellular plasmin done, which is normal, and all the viral screenings were negative. But his CPK was 9,000. So most probably it has come from the a muscle origin due to the seizure or the mitochondrial myopathy. So CPK is the test to differentiate whether it comes from muscles or the liver. But here it's mainly due to the muscle damage rather than the liver cause. Okay, because ALT also is also the place in the skeletal muscles, not to the extent that the AST, but skeletal muscle has also got the minimal level of ALT as well. So if there's a muscle damage, it can give rise elevation of both ACVT and SGOT, but SGOT is the predominant factor you will see in the liver test. So the next patient, 60-year-old, was referred for a transplant assessment with high MELD score. What is MELD? Modified end-stage liver disease index. Okay, so he was clinically well. So this is his liver panel. So by the way, you know that what is a MELD score, no? So the MELD score is to stage the disease and to find out whether they need a urgent transplant or not. What you want is the INR, bilirubin, and whether the patient has undergone any dialysis in the past. So they then there are calculators in this sort of app. You can Google it and see that. And the cutoff is the 14, and then after the 14, we will list the patients for the liver transplant. So those are the things we need. So what are the things? So the INR, bilirubin, creatinine. So this patient is asymptomatic but referred for transplant assessment. So what do you think? So what do you think about the albumin level? You think it's very low or it's marginal?
It's marginal.
Marginal, isn't it? So, the patient has fairly good synthetic function, but obviously I want the INR level as well. So, I don't think that patient is decompensated with this. So, what is the abnormality here? There is a indirect hyperbilirubinemia. So, what do you think the reason is? So, the patient is referred to our clinic with high MELD. What do you think the reason? Maybe.
High bilirubin levels?
Yes, Puto. So I'm asking why its total high bilirubin level has come from. Male is the indirect, isn't it? Indirect hyperbilirubinemia.
Yes.
So what do you think the reason is? Any possibility that the patient is having a Gilbert syndrome?
Gilbert
syndrome. You must exclude. You must exclude the hemolysis or the Gilbert syndrome, isn't it? So this patient was referred because of the high MELD, but you can see here. So the bilirubin, this is total. So although the patient is having a Gilbert syndrome, this will come as a high bilirubin level. So which is not the ideal to calculate their liver stages with the MELD score if there's an indirect hyperbilirubinemia. So the message here is they have referred me with a high MELD, but it's not true because there is an indirect hyperbilirubinemia, not the the true direct hyperbilirubinemia. So a few words about the INR. So it's a marker of current synthetic liver function. If somebody asks what is the best test to assess the synthetic liver function, I would say albumin, INR and the bilirubin. But mainly the INR is a very good synthetic liver function test. So it's useful in the diagnosis of liver failure, and the reliability is a problem because some labs give some different values. So this is Again, a very important test, lactate levels, because it's a very good indicator of current liver function. And it's a product of anaerobic metabolism. It's a marker of tissue ischemia. Because it's mainly excreted by the liver. So if there's an acute liver insult, you might see an elevation of lactate level. So it is very useful in the ICU setting, especially in the septic shock, liver transplantation, dengue shock syndrome. And you should know that if the patient has got liver transplant, so this is the, the initial test we are doing to assess the liver ground, because within 2-3 hours we can know that whether the transplanted liver is working or not by assessing the lactate level, because it's a very good marker. If there's a tissue ischemia or the liver dysfunction, it will give rise to high levels of lactate. So that's all. Any other questions you want to ask? So summary, so all elevations of LFT should be carefully analyzed, because I told you that there may be a lab errors, there may be a unit changes compared to the in the different labs, and then sometimes you can misinterpret the upper limit, the changes in the upper limit of normal. And the persistent and symptomatic elevations are more significant. And be aware of the normal values, and be aware of common benign or relatively benign conditions like Gilbert or Naples, because sometimes patient might undergo unnecessary investigation. Laboratory issues are common, should be careful to avoid mistakes in the diagnosis. The liver functions abnormalities are encountered in many systemic pathologies in which the liver is not directly involved. Like the case I have discussed earlier. So it may not be the sole disease part, but you will see a liver test abnormality because of the systemic involvement. So basically that's all. If you don't have any question, I can move on to some MCQs. Any questions you want to ask? Okay, so I want to answer from one of you. So it's a 28-year-old woman. So found to have the following liver test as a part of routine health check: bilirubin 37, AST 14, ALT within normal limit, alkaline phosphatase 125, with the rest of the normal liver test normal. So what is the most likely diagnosis?
Gilbert syndrome.
Yeah, very good. So why do you say like that?
Because she is having high bilirubin level with normal retic count. There is non-suggestive of hemolysis, and other liver functions are fairly normal.
Very good, very good. So actually, so that's the Gilbert syndrome. So the isolated hyperbilirubinemia with the normal other liver tests. So that's why it's so how do you differentiate? How do you confirm whether it's a Gilbert or not? So you need to do the fraction of bilirubin, isn't it? You need to do the indirect and the direct bilirubin level. So if there's a high indirect hyperbilirubinemia, you can diagnose Gilbert. But if it's a direct hyperbilirubinemia, you have to find out the other causes like Dubin-Johnson and the other obstructive causes. Okay. So can I move to the next question?
Okay, sir.
Okay. So what is the best liver function test is?
INR.
Yeah, very good. So it's a easy question. So the above only the INR is a true liver function because others are liver enzyme. So the AST and ALT are those are liver enzymes which can elevate in hepatocellular injury. ALP is an enzyme which is if there is a cholestatic injury, you will see the high ALT, ALP and gamma GT. Bilirubin, yes, again a synthetic test, but you know that it's elevated in liver dysfunction, but can be elevated with bile obstruction or if there is a hemolysis. So it's not a true liver test compared to the INR. So INR is a solely, responsible for the liver abdomen. So all of the following are causes of acute hepatocellular injury except any guesses?
Hemochromatosis.
Yeah, good. Why? So the hemochromatosis rarely causes elevation in amino acid because it is, you can see a mild elevation, but it does not cause mainly transaminitis. So, but compared to the other reasons like paracetamol toxicity, which can cause a dose-dependent hepatocellular injury, and if there's a hepatic vein thrombosis, you can see the congestive hepatitis, and then the NSAID also can cause hepatocellular injury. So hemochromatosis is the answer because it rarely causes elevation in amino transfer. This may be the last one. So just see. The one before the last one. The initial test in the patient, and the freely available test where you can differentiate whether it's an extrahepatic or intrahepatic etiology. And then you can go for the other test. So what will be the next, the imaging after the ultrasound? What do you know about liver imaging? After that, so if somebody asks, what is the best imaging model to assess the chronic liver cell disease? What is your, the answer should be? The first line, ultrasound, because it's invasive and cheap and freely available. And the second? MRI liver MRC. Okay, so here the answer is liver ultrasound because to differentiate whether it's obstructive or the non-obstructive pathology. So this is, I don't know, it's mainly not the, the liver test, but it's important in patient with cirrhosis. So alcoholic cirrhosis, despite dietary sodium control and diabetes, coming with ascites, and you have done a tap and you have found out high WBC count in acidic fluid with 75% of lymphocytes, and the acidic fluid protein is 3.2 with the SAG. You know that's what is SAG, isn't it?
Yes, sir.
Serum
albumin acidic
gradient is 0.8 grams per deciliter. What is the most likely diagnosis here?
Tuberculosis, peritonitis.
Why you are telling that?
There is high lymphocyte count other than the increased.
Very good, very good. And the other reason, SAG is?
And now SAG is less than 1.
Less than 1
GD.
Less than 1.1, which is an exudative. Yes. So that is the thing. So, so that is the reason. So the tuberculosis peritonitis is the answer because mainly it is an exudate. All right then. So any other questions? in the lecture? Anything you want to clarify more? I don't think I have covered all the, the liver test abnormality, but I found that by discussing the patient rather than putting the slides, you will differentiate the abnormality, and then you can appreciate the liver test, the abnormality. So any other questions you want to clarify or ask before I know? Shall we enough? Thank you very much for your attention. And so if
Yes,
there
sir.
are any other, you have sent some question. Yeah. Yes.
On behalf of all the students, I want to thank you for this wonderful session. And it was really engaging and enjoyable, and we also know that you have a busy schedule, and to spare your valuable time to something we are truly grateful. And also I want to thank PeMSAA for organizing this opportunity. Thank you very much. Good night.
Okay, no worries. Okay, bye. Good night.
Good night, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.